right, good afternoon, everyone. So I wanted to take this time to once again thank you for joining our FMDA Journal Club. Today we are going to talk about long haulers. And to start, I want to make sure first that you can hear me appropriately. But I'm gonna ask Jackson if you could go to the agenda slide for me. Yeah, so I want to start where we have started in the past, talking about the state of the state. Then we're going to go through some research and clinical highlights. And we had a couple of our members from our task force send in some case reviews to discuss. So hopefully we'll have a lively conversation and we can go ahead and get started. And if you want, Jackson, you could go to the next slide for me. So wanted to take a look at the data and our dashboard that we've been utilizing from Johns Hopkins. We know that we have over 33 million cases. And unfortunately, we passed the 600,000 mark for deaths about a week ago. We also know that we are still seeing a lot of cases around the world, and that this virus isn't going anywhere despite the number of people who've been vaccinated. If we go to the next slide, I wanted to share with you the view of the states. And when we look at this, you keep in mind, we're not getting all the states' data anymore. As you can see, if this is not too much of an eye chart, you'll see that Florida's data is not on here, but that's because of some of the standards and reporting standards that have changed. But looking at this just from an overall view, we do see more states who are below the 5% threshold, which is a really good news, as we are seeing openings pretty much throughout the country, especially following some announcements made back in May around masking for vaccinated individuals and how you can go without masks. We've seen a lot of reopening. Our 7-day moving average for positivity rates in the United States is at 2.6%. And as of yesterday, June 22nd, we had about a little over 12,300 new cases for COVID. So it's not so bad. We're doing pretty well when we're thinking about it that way. When we look at the state level, if you go to the next slide for me, Florida has been doing relatively well as well. Our positivity rate, this is through June 17th, was at 3.3%. We are seeing more individuals complete the series of vaccinations, so that is very encouraging. Unfortunately, not universal throughout our nursing facilities. And there's still a lot of opportunity, but very encouraging signs. When we look even further at the COVID vaccinations in the United States, if you advance to the next slide for me, what we are finding is that we are over 300, actually over 300 million vaccines being administered. While that does not get us to that lofty goal that we were trying to obtain of 70% back in, I think that it was part of the Biden administration to get up to 70% by July 4th. Does it look like we're going to actually get there? We'll probably be a little short of that, but we do see 65.5% of adults having at least one vaccination with, which is good news. If we go to the next slide, wanted to just take a moment and highlight the fact that we are still seeing a lot of variants. The UK variant, which is the B.1.1.7, is still the most predominant variant that we have out there, but we have seen more cases in the United States of B1617.2, which is the Delta variant, which originated in India. So I believe headlines broke where we were seeing about 10% of those cases, new cases, be the Delta variant, and it is growing at a pretty rapid, spreading at a pretty rapid rate. It is now a variant of concern. It is something that we have to be mindful of, especially given the fact that we are seeing some states that have very low vaccination rates compared to the rest of the country. If you go to the next slide, what I want to spend the majority of our time talking about is long haulers. And when we are looking, we're going to stay here for one moment. When we're looking at long haulers, what I really want to make sure we're defining appropriately, and we're going to talk a little about this a little bit later, is what that means. About a year ago, during the height of the pandemic, we saw that this condition was being described in a lot of testimonials from patients. It made its way through a lot of the social media platforms and found itself on the mainstream media. And we were describing this as long COVID. And there are videos and testimonials on YouTube and that were written up in other journals where we started describing this long COVID and the fact that we were seeing persistent symptoms in patients who had recovered from COVID. So they may have continued to have headaches, and they may have continued to have trouble with breathing or feeling that fatigue, which were some of the more common findings. Back in June, July, August, there was a lot of skepticism around this from the medical community, a lot of questions, which we definitely needed to ask. And we started seeing it even being reported in our medical communities with our nurses and our doctors who had recovered from this infection. When it all settled, we saw that about 10%, a little over 10% of the patients who had survived COVID were experiencing these persistent symptoms. Reports came in about the persistent shortness of breath 3 months following their diagnosis, fevers and bouts of fatigue and headaches. And we started even noting, as we started tracking this, that these cases were occurring even for those individuals who had mild or asymptomatic COVID. So it became very interesting. And if we go to the next slide, the NIH earlier this year announced that it was going to now start really looking at these long-term symptoms, anything over that between that 4 to 6 month and longer period, because we wanted to understand how long do these symptoms linger and what is the effect on quality of life and the recovery as a whole. So back in May, this announcement came out in February, and back in May, it was announced that the NIH is actually starting its own study where they're really looking at how to make sense of all of this and what does this mean for the long-term recovery of COVID. So it's an interesting space because we've talked so much about the other metrics about acute hospitalizations, and we've shared a lot around how many people are died, but there's a lot of conversation that needs to be had around how do we rehab individuals, what are we seeing in both the outpatient community and as well as the post-acute long-term care community. I want to start though with some of the research. So if we go first, yes, thank you, Jackson, to the Lancet. This looked at the 6-month consequences of COVID in patients discharged from hospitals. And the background for this study really states that they were trying to understand the symptomatology that happens 6 months post being being negative for COVID following a hospital stay. They wanted to investigate disease severity and any risk factors. And so they did this cohort study, and this was based off of out of Wuhan. So they looked at all of these patients, and what they were finding is that of about the 2,400 discharged patients that they were looking at, over 1,700 people were still complaining of symptoms. Those symptoms range from fatigue, muscle weakness, and sleep difficulties, and a lot of complaints around anxiety and depression and those kind of things as well. What we also were able to see is that even after this period, those complaints were still being present. And so it was really interesting when you think about how long we're seeing these findings. And they were able to look at other studies and still see that there was an impact to the overall quality of life, an impact to what they were seeing when we were trying to have people exercise, and even when those studies, the studies such as a CT scan or radiographic studies with chest X-ray, even when they did not show any lingering findings, they still saw that people were complaining of shortness of breath or having persistent coughing, and some of those other symptoms were still persisting. So that was a pretty interesting study, and it made me want to go back and look at the things that we do know about COVID. And if you advance to the next slide, this is something that I think we're very much aware of. The now cytokine storm that we all talk about with this condition, that acute hyperinflammatory response that can impact multiple organ systems. And it was partly the hallmark of this condition, the fact that it was impacting so many different systems, from the lungs to the GI system, the neurological system. And as we discussed at our last journal club, we were even seeing skin manifestations at that time. So we know that we are seeing a multitude of different systems being impacted in real time during the acute phase of this condition. The reports of thromboembolic disease, vasculitis, especially in the multi-inflammatory conditions that we saw with children, were really well noted and documented. And that pathophysiology, they all went back to the fact that of this cytokine storm. So it makes us realize, I think, that there was going to be some long-term impact when we're looking at the way we recover. So I don't think that's at all surprising. But when we're trying to understand the chronic component of COVID, and there's like 1,001 names for long COVID or long haulers, there's some interesting assumptions that were being made early in the course of this pandemic. If you advance to the next slide, this is from a neuroscience journal, and they were really looking at what happens after you've had COVID. How do we transition to chronic COVID, and what are the possible theories? So this study, neuroscience journal, it really looked at the neurological syndrome seen in long haulers. And it asked the question if there is an underlying degeneration, or is this secondary to low-grade inflammation, or could there possibly be cellular degeneration at the neurological, in the nervous system. It also asked if this was secondary to vascular effects with endothelial inflammatory markers being noted. So it's interesting that we're already this was published back in December of 2020, but really early on, we were already trying to figure out what is causing these long-term effects that we're seeing, which we started calling brain fog and dizziness and inability to concentrate, what could be behind all of that. So if we look at what we now know about the pathogenesis, there's still reports, that we still don't have all the answers. It's really multifactorial. It is thought to be secondary to prolonged inflammation or in an immune-mediated vascular dysfunction. There's also the concerns around the nervous system dysfunction and thromboembolism, and all of these things are going into giving us this post-COVID syndrome. So there's still a lot of things that we don't know about what's actually happening. One particular approach, though, is when we are now looking back at some of our patients and looking at those case examples. There are a lot of great case studies out there in different journal articles. Most of them are either editorials or a part of like a research letter, but it is interesting to see when you, and looking back, just how far we've come in our understanding of what's happening. One such article was from JAMA, and it appeared in their open network, and it was looking at the sequela of adults at 6 months. So if you go to, yeah, thank you. After the COVID-19 infection. And this was interesting because we had talked so much about what happens to those people who are hospitalized with severe disease, expecting that they were going to have a lot of issues following that recovery. We anticipated that, but this study really looked at those individuals in the outpatient setting, because they felt that that they weren't really being captured or well characterized. And it focused on individuals who were 110 days out. And then they took a subset of those individuals who were hospitalized versus those who were not, and just looked at what we were seeing. As we looked through, we were able to find that, individuals with this were complaining of symptoms that had persistent symptoms, even for 6 and 9 months following the illness. They found that approximately 30% reported persistent symptoms. Those individuals who were treated as an outpatient had mild disease, and yet 1/3 of them were still complaining or stating that they had persistent symptoms. And this really makes us have to take a moment and take a step back, because earlier in the pandemic, we were like, if you have mild symptoms, you're going to recover, no issues. But we are still seeing people who are with complaints of GI symptoms and brain fog and headaches and bouts of fatigue, even with mild disease. And we saw in this study even a few individuals who had asymptomatic disease still reporting that their quality of life had worsened, that they were easily fatigued. So a lot of interesting information from here. If we advance to the next slide, there was another study that came out of Nature Medicine that talked about post-acute COVID-19 syndrome, and really with the goal to look at the pathophysiology and the organ-specific effects that we're seeing for individuals who have this these prolonged symptoms. If we go to the next slide, this is also, and I apologize for all the eye charts, but I thought this was a great graphic because of the way it demonstrates the trajectory of disease and that timeline. So we know that the acute phase of COVID, it usually lasts about 3 to 4 weeks from the onset of symptoms. And beyond that, that's really that post-acute period. And what we're defining as post-acute COVID symptoms are persistent symptoms beyond that 4-week mark that are either delayed or long-term complications of COVID. So what we're seeing is that there are, not only do we see problems with the musculoskeletal system with fatigue and muscular weakness, joint pain, and overall reports of decline in quality of life. At the respiratory system, we have individuals reporting persistent cough, dyspnea, and occasionally persistent oxygen requirement. Neurologically, we've seen an increase in the anxiety and depression, but also is sleep disturbances, cognitive disturbances, and headaches. And then there have been reports when we look at the cardiac system of palpitations to the point where people are now being medicated for those palpitations, and as well as atypical chest pain. There are also cases where we are now seeing individuals who are in this post-acute phase have blood clots, DVTs, impairment, further impairment of renal impairment. If they were normal, you may see them like now with what we would call chronic kidney disease, and some even advanced to end-stage renal disease. And then there were also reports of the skin manifestations, as we discussed the last journal club. We were seeing skin manifestations. This study really highlighted the fact that we were seeing hair loss at week 12, as some 6 months later there were still these complaints. So it's really interesting to just get that timeline down, and the fact that we're still seeing these issues as we're moving into that phase where we would probably be trying to rehabilitate a patient in our facilities, or with home health care, or in other aspects, and you start seeing that there are still some prolonged effects. This study, I also like that they really talked about the fact that if we're going to get in front of this or treat it, we have to approach it from an interdisciplinary approach. And if you advance to the next slide, they talked about that multidisciplinary collaboration that you would need to have, which would involve an aggressive physical therapy programs, getting any other disciplines who need to be involved. It's just interesting, especially now that we're seeing a lot of post-COVID clinics being stood up. Between the Mayo Clinic and Johns Hopkins Clinic and a lot of other places in the VA, everywhere, we're seeing that there's a bigger emphasis being placed on how to deal with these post-COVID symptoms. If we keep going, just wanted to talk about another study that was recently published in JAMA, where they looked at the assessment of the frequency and variety of persistent symptoms among patients with COVID. And the objective was to review all of these studies that have been looking at these symptoms, because there's so much variability between studies. When we are looking back through the hundreds, or now it feels like thousands, but maybe still hundreds of studies. And actually, now that I say that, I think this looked at over 1,200 articles were screened. So it is thousands of case reports and studies that we have now access to. They wanted to really figure out, okay, where was the commonality between all of these, and looking at how we define these symptoms at the 30-day mark versus 60 days from recovery. What they found was that it was very common to see symptoms persist beyond the acute phase of infection, and that there was a significant implication on health associated functioning and quality of life. So if we go to the next slide, this is sort of how they categorize. And this is you will have access to these slides. So this is definitely an ICE chart, but it really looks at all of those symptoms that were being reported. And over 72.5% of those patients had at least one symptom at the 60-day mark. Findings show that even when they went out 6 months, they were still finding individuals who, a significant amount, over 30% of individuals, still complaining of at least one of these persistent symptoms. So in thinking about that, I also wanted to think about the other perspective, because as I was trying to piece this together, it feels like forever, trying to have this conversation. What I kept getting back from my colleagues is that we're not really seeing this in our nursing facilities. So I pulled a paper from JAMDA, if you go to the next slide, and this looked at the recovery from coronavirus disease among older adults in post-acute skilled nursing facilities. So they were really comparing those people who had come into the facility with a positive, with a history of having COVID, to those who were negative, and how did they fare. And they found that that there were pretty much the timeline to discharge was pretty much similar between those two populations, unless frailty was unless the frailty score was high in those members, those patients who had COVID. So in looking at it that way, you know, it makes you have to just ask the question, if is what we're seeing more frailty versus post-COVID? And it's something that I think we haven't yet even began to do enough studies to answer completely, because we do know that that there are a lot of manifestations with frailty, and it is something that can impact multiple organ systems. But what was coming first, or is this COVID that is lingering that is now causing this person to be frail? So a lot of questions. And I want to, you know, from this point, pivot to some case reviews. And like I said, I thank everyone who shared these case reviews with us, because it's really interesting to just get a view of these patients and seeing what we're actually seeing in the community. So I want to start first with the young geriatric patient, is what I called after reading this case, because it's a 52-year-old woman who has multiple comorbidities, who was being seen as an outpatient, history of morbid obesity, polycystic kidney disease, end-stage renal disease, on dialysis, hypertension, and COPD, and she was admitted to the hospital with shortness of breath, cough, and a positive COVID test. So she was discharged, you know, pretty early in her, after her diagnosis, with mild shortness of breath. Discharged home with home health at that time for RN evaluation and a physical therapy evaluation. But it was interesting in looking at this, the patient became so debilitated that she had to have the physician visits and the nurse practitioner visits at home, because she was feeling that she was too weak to come to the office. 1 month after that discharge, she still had a cough, shortness of breath, and fatigue, and was requesting more assistance at home due to weakness. So at that point, they did order for home health aid and some other services to be given in the home. She was hospitalized then 2 months later, after an episode of which she stated was her feeling dizzy, that resulted in a fall with an ankle fracture. So per the story, the patient was outside of her dialysis center, felt dizzy as she was trying to walk into dialysis, and had a fall and a resulted ankle fracture. Upon discharge from that hospital stay, she also went home with home health care. She refused to go to a nursing facility at that time. And when she returned home, the home health nurse who did an evaluation within, you know, the next morning. So she went home that evening, did an evaluation that next morning, which was very wonderful for a home health visit. Noted skin lesions and a macular rash on her chest and on her breast, and she was sent back to the hospital. And at that time, she had persistent cough, and she was also experiencing confusion. This then resulted, and I just put the highlights here, this then resulted in multiple hospitalizations, where this patient was treated for 2 to 3 weeks in the hospital, and then was readied and got to the point where she could go back home with home health, and would end up bouncing back into the hospital because her family felt that they couldn't provide care. The reports that, per what was written, is that the family kept expressing that she was having these bouts of confusion where she did not know where she was at, and that was very much different from her baseline. So where we're now are at now, over 8 months status post her diagnosis, is that she is now hospitalized again, and there is a consult pending for hospice. And I just thought that was interesting because when you go back to the history, even with all those comorbidities, this was an individual who had been quite active. She enjoyed going to the gun range every Sunday morning, apparently, and she was able to do certain tasks without any assistance at home. And we just saw this progressive decline in her condition following her COVID-19 diagnosis. I'm going to pause there and go to the next case. And this case is a 62-year-old woman who was in the long-term care facility. So she's an African-American woman with a past medical history of diabetes, strokes, chronic kidney disease, stage 3, morbid obesity, hypertension, heart failure, COPD, and rheumatoid arthritis. And she was noted to be positive in the facility. They did not need to transfer her out because she was having mild symptoms at the time of diagnosis. And they moved her to the COVID unit in the facility. At that point, the patient started having respiratory difficulties, went into acute respiratory failure. It was transferred out to the hospital. Now, from there, she had several interventions in which they report that she was on BiPAP and she was treated and stabilized at the hospital. And when they were able to transfer her back to the facility, they received her. She was on oxygen. She was on several antibiotics, but they were able to put her in for rehab and do certain things. But they noted that her renal function had worsened yet again. So when we looked at this case, what was interesting is that this patient started having worsening renal function and persistent shortness of breath. And upon discharge back to the facility, she was also complaining of muscle weakness. She then was transferred back to the hospital for worsening renal function. And at that point, this began a cycle of her being sent back and forth to the hospital with worsening renal function, worsening shortness of breath, heart failure, and weakness. She had to be started on dialysis, I believe, after the second hospitalization, and her condition continued to worsen to the point where, following, I believe the practitioner informed me, over 6 hospitalizations within a year, she now has passed away. And before we go to discussion, I just want to talk about one other case that was shared. And this is an 81-year-old female long-term care resident whose past medical history includes COPD, heart failure, atrial fibrillation, hypertension, status post strokes, diabetes, and peripheral arterial disease. At baseline, this patient had mild cognitive impairments, normal oral intake, was totally dependent for transfers, and otherwise it was reported per the nursing staff that she was alert to her name and to her place. She was diagnosed with COVID-19 with mild symptoms, mild shortness of breath, no fever, no chest pain, treated in the facility. 1 month later, she had significant mental and functional decline, worsening renal function, and poor oral intake. Now, they didn't state if she had lost any sense of smell or taste. But the question that, her disease trajectory suggests is that she continued to have worsening decline over the months following her diagnosis with COVID. The predominant symptoms were worsening renal function, worsening cognitive function, muscle weakness, and worsening swallowing dysfunction, to the point that she transitioned to hospice and subsequently passed away as well. So the question that, I think that's up for discussion is whether what we're seeing with these cases of individuals who may initially recover and then are either presenting back to us in the office with all of their comorbidities or into the nursing facilities and having steady declines, if this could also be part of that post-COVID syndrome. And we're going to open it up to discussion in a minute, but I wanted to just redefine the post-COVID syndrome. So if you go to the next slide, according to what's on the CDC, we're highlighting fatigue, that difficulty thinking or concentrating that's been referred to as brain fog, difficulty breathing, cough, painful joints and muscle aches and weaknesses, chest pain, depression or anxiety, headache, fever, palpitations, the loss of smell or taste, and dizziness, as all part of this post-COVID syndrome symptomatology. I would also add the rashes, hair loss, and lesions on toes, which we talked about on our prior journal club as potential parts of this post-COVID syndrome. And the reason that we're really trying to define this is because we're trying to get a better understanding of what we should be relating back to this these persistent lingering symptoms, how we should be documenting and relating all of that. I say that because what happened recently, and if you go to the next slide, you'll see that there's now recommendations that the World Health Organization has now added a new code to the ICD-10 list, code U09.9, which is for post-COVID-19 conditions. That proposal was made at the March 2021 meeting for ICD-10 coordination and management, and has been accepted. And the comment deadline window has already been closed, has been accepted. And what we're seeing now is that this is going to be implemented on October 1st, 2021. So we now have a way to really describe everything that we're seeing as under a code. The question becomes is, what is it post-COVID syndrome, and how are we actually looking at it and defining that? And with that little bit of controversy, I open it up for discussion. I see that we had some questions from Pam. How are we differentiating between long COVID versus debilitation from having recovered from COVID in our residents? Sees if this is differentiating may be difficult with our patient population. And the second question was, how can we differentiate between the person's innate frailty from long COVID? And I mean, those are both very interesting questions. From the research that I've been looking at, I think that the one thing that is interesting is, when we have the frailty scores before they develop COVID, that's always helpful, because it really is hard. Everything that I've been reading to really differentiate if this is worsening of the condition. We know that our patient population do get worse if they've had prolonged ICU stays or prolonged hospitalizations. So how do you make that differentiate? You should definitely need to know what their baseline was and what's happening now. A comment that came in, another comment was about the psych issues that we're seeing. If at baseline before COVID, that we had no cognitive impairment, and now we have significant cognitive impairment 3-4 months out, I think you can easily say that this is probably cause secondary to that. But if it really does come to knowing and understanding the baseline, in my opinion. And if anyone else has any other opinions, I would love to hear them. Right. So I think as what we've also seen to a point that Carmel raised about the psych issues, depression and anxiety are being categorized as part of this post-COVID syndrome. And I think, again, I don't know if it's a chicken or an egg thing. I don't know how one would feel after having COVID. Fortunately, I have not had that experience, but it is interesting to see that there are so many mental health concerns and challenges for those individuals who are now post-COVID and surviving COVID. But I don't know how to categorize that either in our patient population. I think we just need a lot more research, a lot more case studies. And from looking at everything, this is just me probably being on a high horse, I honestly did not find enough information in our journals, the ones that I probably turn to first, describing what we're seeing in our nursing facilities.
Good afternoon. My name is Carmel, because working on the long-term care, what we seeing with our members versus the post-COVID, how do we recognize the symptom? They are really acutely ill with no recovery. And then the declining is so fast and so progressive, because we know when we used to have the nursing home members, you see them, and then they are progressing really slowly until something. But now with the COVID, acutely they progress rapidly, and then it's consistent with weight loss. The muscle weakness still there, doesn't go away. And then they are more prone for more infection. And then you do the chest X-ray, and then they are okay, the chest X-ray is showing you patchy density instead of it saying a pneumonia or versus a atelectasis. So it's more likely when you know your patient, and then when you know what you used to do for that patient, it's really you will see the decline. It's acute and then fastly progressing versus the slow progression. They are not eating, and then you want to do this. You want to put them on a restorative. Even though you're using the skill therapy, put them on speech, physical therapy, they don't come back. With the COVID, it's they staying where they are.
That's interesting.
That's what I noticed.
So my question back to you, Carmel, would be, have you seen any cases where you've been able to successfully rehab those individuals at that point?
I will say it's really rare, but with the vaccine now, we do see with the vaccine, we see that the changes, because prior to the vaccine, it was what are we going to do if the person get another COVID? If the person is tested again for COVID, and then some of them, they are tested twice or 3 times. And then some of them, they are positive for COVID twice prior to the vaccine. So with the vaccine, we see some relief, but it depends on the chronic comorbidity that the patient has. That's going to take a toll on that person. And like you said, we need to do more research to really find out where are we, and then what's going to continue to be doing. And then not only that, for us as healthcare providers, everybody notices it, because the lack of staff that we have in post-COVID. So we are okay, let's go ahead and try to do that now on our sector. We're trying to just go ahead and hydrate our members, because during COVID, nobody was offering the fluid. And then now when we look at them, and then with the kidney that you mentioned, that on both of your case studies, we saw like the worsening on kidney function. Those patients are so weak, they cannot even drink the cup of water they put at their bedside. So there's a lot of research we still need has to do to just go ahead and really differentiate and then see where we're going with our nursing home population.
Yeah, that's what I've been trying to understand more, and that's why, you know, if you're on this call, you have cases. The more cases that we could get, the more we can understand and compare what is working and what isn't working. It would be helpful. I've now seen that there are webinars coming up from that physical therapy perspective on what they're doing, and looking forward to engaging in those platforms, because getting them to a point where you're strengthening them is where I think is the biggest challenge and the biggest opportunity. To the question about foggy brain and muscle weakness, what I've seen as far as treatment plans has all been around increasing exercise and physical therapy. I've not seen any information on treating with any medical interventions in the geriatric population, the post-acute long-term care geriatric population. And I don't know if anyone else on the call has a different experience. So the question I think that we also need to be addressing as we're documenting, and to the point that was made earlier, I would highly recommend documenting where your patient was at their baseline pre-COVID, and when you're talking about any post-COVID symptoms. If you, once that code goes live, if we start utilizing it in our facilities, make sure you are also looking at what manifestation you're seeing. So if it's shortness of breath or chronic dyspnea, you code for that, as well as the post-COVID. And if, like I said, if we could get more write-ups, I think it would be very helpful. I do agree to the person who just sent me the message about falls. We are seeing many more falls, many more injuries, and we really need to, I think, talk more about this in our space. You know, how are we treating these individuals? Now, with that, I don't know if anyone else has any other comments, any other things to bring up, but I want to just say, and we could advance to the next slide, Jackson. I want to just say thank you to everyone. This, doing these sessions throughout this past year, which feels like 10 years, has been really amazing. We will be returning to our monthly sessions starting in July, and so look for that announcement. This doesn't stop our conversations about COVID. There's so much more to talk about, so much more to do. We just won't need to devote some of that time to doing those things. So we will still be here. We will still be doing Journal Club. We will still be having discussions. Our library will still stay active. And we thank you all for joining us since, March of last year. I'm now going to turn everything over to Tanya Masterson, who's going to introduce our product theater. And I do thank you all for your time today.